Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is HIV-TB co-infection, case finding, management and prevention of tuberculosis. And the speaker is Dr. Rajeeb Day. Dr. Rajeeb Day is a technical specialist public health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Thank you, Sweta, and good afternoon, everybody. So today's subject matter is HIV-TB co-infection, particularly case management, case findings, prevention of tuberculosis. This has been taken from the National ART Guideline 2021 of NACO from chapter number 2.8. And as a part of National Distance Learning Seminar, this has already been taken long back, and there were other RDLS also which were taken on the topic. So basically today's topic is a recapitulation of those previous sessions, and it is a very content heavy topic, so we'll be bypassing some of the slides, and we will try to discuss about the basic principles of management of HIV-TB. So in the session, our objectives are to know the HIV-TB co-infection, what are the good practices that are to be followed, and general principles of management of TB in PL-HIV, and what are the drug side effects and drug-drug interactions of ART with ATT, and management of CL-HIV co-infected with tuberculosis. Now, case finding and management. So, in PL-HIV in India, we know the incidence of tuberculosis is quite high, and most of us have contracted this infection sometime early in our life. Maybe 50% of all the general population of India are infected by tuberculosis. But these have been contained because of our strong immunity in the form of primary complex or gonfocus. But in PL-HIV, because their immunity is compromised, so we find around 18 times more chances of tuberculosis in a PL-HIV than in general population. And the presence of this tuberculosis and HIV increases the HIV, predispose the person to have tuberculosis more often than general population. And having tuberculosis in a HIV patient also cause acceleration of the disease progression of HIV. Now, in India, in 2019, there were 71,000 cases of TB recorded in PL-HIV. Now, to know a little bit of HIV-TB and how they interact, first, when the person is infected with HIV, there is immune suppression. We know the CD4 count goes down, and this CD4 is the prime site for pro-inflammatory marker, pro-inflammatory cytokines, particularly interferon gamma. And as the pro-inflammatory cytokines goes down, the mycobacterium that were contained in the gonfocus in a PL-HIV get reactivated, and there is clinical disease. And with the disease, there is more macrophages, cytokines like interleukin-1, 6, and tumor necrosis factor. And because of that, there is more of viral application. And this viral replication gives rise to HIV, AIDS, and there is further worsening of immunosuppression, and the cascade goes on. The cycle goes on repeating this way. So to stop the cycle, we need to either start treatment of AIDS, or we have to start treatment of tuberculosis. But if we start treatment of HIV on the first, then there is chances of virus, and the patient may die of severe form of tuberculosis. So our idea is to start treating tuberculosis first, so that there is no chance of iris. Now, what are the principles of management of HIV-TB? Basically, there are 4 principles. First, because there are high prevalence of tuberculosis even in general population. So in HIV, when we know that the presence of HIV increases the likelihood of acquiring tuberculosis, so we proactively go for searching 4S complexes in the PL-HIV. So this is known as intensified case finding. And once we can diagnose that a person is suffering from any of the symptom of tuberculosis, particularly those 4S symptoms, then we promptly refer the patient for diagnosis and under to the as per NTP guideline. And if the patient is found to be confirmed tuberculosis, then we start ATT at the earliest. And we also provide cotrimoxazole therapy to those patients for prevention of other opportunistic infection. This tuberculosis is important because we know not only the prevalence of tuberculosis more in general population and more so in the case of HIV, but also it is one of the major cause of mortality also in PL-HIV. So the 4 symptom complexes in adult and children is a bit different. First 2 symptoms are common in both, that is current cough and fever is both in adults and children. Weight loss in the case of adult, while in children it is poor weight gain or reported weight loss, and night sweat in case of adult and adolescent, and for children it is history of contact with a TB case. Now, if any such symptom is positive in any of the CL-HIV or adult PL-HIV, then we send for to test for tuberculosis. If TB is found, we need to treat the patient. If TB is not found, then we can start IPT if there is no contraindication. And if there is no TB found, but there are signs and symptoms of other diseases which is causing this current symptoms, say for example, pneumonia, then we treat that entity and thereafter we also start IPT. Now, the diagnosis, as we said, once it is found to be positive in any of the symptoms of tuberculosis, 4S symptoms, then we send the patient for CBNAT testing. And in CBNAT testing, we get 2 reports. One, whether the patient is reactive to, having tuberculosis or not, and if the patient is having tuberculosis, whether it is sensitive to rifampicin or not. Now, if the patient is found to be rifampicin resistant, rifampicin sensitive, then we start ATT in the ART center through the single window, and we provide 4 FDC. And simultaneously, we send sample for first-line LPA to know whether the patient is having INH resistance or not. If later on we find that the patient is having INH resistance, then we send the patient to DRTB center. And if rifampicin is resistant with the CBNAT test, then we directly send the patient to DRTB center for the management of ATT, for the management of tuberculosis. But if the CBNAT is not possible, say for example, the facility is not available, or if the sample is not available, say for example, in the case of EPTB, then we evaluate for other tuberculosis with other diagnostic tests like chest X-ray, sonography, abdomen, maybe CT scan of brain. And there is another test which is not included in the NTP guideline, but in the national guideline of ART, we have a TB LAM, that is a lipid arabinomannan test, which is quite good in picking up presence of tuberculosis in the form of positive LAM test in urine sample, both in EPTB and in pulmonary tuberculosis, if the CD4 count is less than 200. So this thing also we can use in ART center if our government approves it, but till now it has not been approved by DCGI, but it is included in the national guideline under the topic of advanced disease management. Hope those who are working in the ART center have actually gone through the management of advanced diseases. So there we can do it if the government of India approves it, but it is not yet approved. So classification of tuberculosis, because this management of tuberculosis in the ART center is done through the single window, but as per the guidelines of the NTEP. So NTEP classifies tuberculosis in the form of, say, microbiological classification is microbiologically confirmed TB or clinically diagnosed TB. Now, microbiologically confirmed TB is one where we test result of positive test result on the microbiological test. So, for example, CBNAT or AFB, sputum for AFB test is positive, then we call it as microbiologically confirmed. But in those cases where test is not possible because of lack of sample or because of lack of infrastructure, then we can go for other supportive clinical and laboratory test which points to a diagnosis of tuberculosis, and we call it as clinically diagnosed tuberculosis. Now, as per basis on the anatomical sites of involvement of tuberculosis, it can be divided into pulmonary tuberculosis if it infects the parenchyma of the lung parenchyma or the tracheobronchial tree. And any tuberculosis which doesn't involve the lung parenchyma or tracheobronchial tree is considered as EPTB. So in EPTB, one important thing is that the pleura and pleural effusion, though they are in the lung, but these are considered as EPTB because it is not neither parenchyma nor the tracheobronchial tree. Now, on the basis of history of tuberculosis treatment, it can be the patients can be divided into three types. One is not three types, 3, 4, 5, 6 types. One is new, that is any patient who never experienced any ATT in the past or has taken ATT for less than 1 month is considered as new case. And previously treated patients are those patients who received tuberculosis for 1 month or more in the past are considered as previously treated patient. And recurrent case is one where a previously treated patient is declared as successfully treated or cured, or the treatment outcome was treatment completed, and the patient subsequently found to develop microbiologically confirmed TB. Here, important thing is that the patient has to be microbiologically confirmed TB. Otherwise, if the patient is not microbiologically confirmed, but on the basis of clinical and other investigation finding, we find that the patient is having clinically diagnosed TB, then the classification would be in others. It will not come under recurrent case. Now, treatment after failure. Any patients who was previously treated for TB and whose treatment failed at the end of their most recent course of treatment is called as treatment after failure. And treatment after loss to follow-up is any patient who did not come for pill pickup for more than 1 month is considered as treatment after loss to follow-up. Now, on the basis of sensitivity to ATT, the tuberculosis can be classified into drug-resistant tuberculosis or drug-sensitive tuberculosis. Now, drug-sensitive means that the patient the tuberculosis is sensitive to first-line ATT, that is rifampicin, isoniazid, pyrazinamide, and ethambutol. And drug-resistant TB means the TB bacilli is resistant to one or more of the anti-TB drugs. Now, MDR-TB is a subset of DR-TB where the TB bacilli are resistant at least to isoniazid and rifampicin with or without resistance to other first-line drugs. Now, regimen for new and previously treated drug-sensitive TB is, we all know, it is 2 HRZD and 4 HRE, and to be taken once a day. So the different doses as per the weight band of an adult PLHIV, they are in the table form, which is good practice to have this table ready on our desk while we treat patient. Now, the most important thing here to remember is that any patient who is below 18 years is to be treated as per pediatric dose chart, and anybody who is more than 18 years to be treated as per adult dose chart. And if after starting a patient on ATT, the patient develops more than 5 kg weight, or if he goes into the next weight band, then we also need to increase the number of pills to that patient. And loose TB drugs can be utilized for substitution of any molecule from the first-line drug if there is any drug-drug interaction or side effect. And these loose drugs are not available in the ART center, so we'll have to refer the case to the DTC. Now, streptomycin, which was used in the first line, is no more used in first line. It is now being considered as a second-line drug. And administration of other drugs which have hepatotoxicity can interact with ATT, because ATT are also having a hepatotoxicity, and other medicines like fluconazole, which are commonly prescribed in PLHIV, also have significant hepatotoxicity. So there is added toxicity, and we need to follow those cases closely through clinically and through laboratory investigations periodically. So the schedule is at least once a month. We need to monitor the patient for clinical improvement, signs and symptoms of drug toxicities or drug-drug interactions. And the laboratory test that pulmonary tuberculosis, we send sputum smear for microscopy at the end of the treatment to know whether the treatment is successful or not. And here it should be mentioned that CBNet should not be repeated because CBNet is only for diagnosis, not for, we should not use it later because the dead or dying mycobacterium also give rise to positive net test. Now, having defined, classified the tuberculosis, diagnosis, and starting off first line ATT, let us discuss about adverse effect of ATT and drug-drug interactions of ATT and ART. So these are the individual side effects produced by individual ATT, but hardly a patient comes to us with that well-demarcated signs and symptoms of a toxicity. So let us discuss how the patient present to us in an ART center. The patient may come with upper abdominal pain, with or without nausea, and these are possible with any of the ATT. Now, nausea and vomiting accompanied with signs and symptoms of jaundice is mainly produced by pyrazinamide, thereafter rifampicin and isoniazid. And loose stool, that is more than 4 times, or liquid stool is produced by isoniazid and rifampicin. Itching or rash is possible with ethambutol, rifampicin, and streptomycin. And severe form of Stephen-Johnson syndrome or TAN is possible with the same ethambutol, rifampicin, and streptomycin. Now, why it is mentioned twice is that for minor rash and itching, we can continue with the ATT along with antihistamines and other supportive measures. But in case of severe rash involving the mucous membrane, in the say for example, in the case of SJS or TAN, we need to stop all the ATT. Now, anemia can be presented with tiredness, lethargy, headache, pale look, and palpitation. And these are possible with most commonly with isoniazid, then rifampicin, then pyrazinamide. In isoniazid, it is also seen in IPT or TPT also. In some cases, you can find anemia. Then toxicity can be possible with streptomycin or any other glycoside, but these are not routinely used in the first line ATT. Then kidney toxicities, mostly due to streptomycin and other aminoglycosides. Here, regarding kidney toxicity, we should not attribute all the toxicities to ATT because in ART arm also, we have many ARVs which have nephrotoxicity, say for example, tenofovir. Then giddiness, feeling abnormal, and these things are produced mainly by streptomycin and isoniazid. Tingling, burning, numbness, that is peripheral neuropathy, is mostly produced by isoniazid. Seizure or convulsion and psychiatric disturbances are also produced by isoniazid. Now, drug interaction, rifampicin and rifabutin. So we know rifampicin is a potent enzyme inducer, hepatic P450 enzyme inducers, and PI and NRTI are also a substrate for the same enzyme system. So if we use rifampicin in presence of PI or NRTI, then there will be less reduction in the blood level of the NRTI and PI, and there will be treatment failure, ART treatment failure. So we should not use rifampicin along with nevirapine and PIs. However, efavirenz can be used, and rifabutin can be used with PIs and efavirenz also, but it should not be used with nevirapine. Now, coming to other ARVs and the interaction with rifampicin or rifabutin. So, for example, NRTI, zidovudin, tenofovir, lamivudin, or abacavir, which are there in the program. We can use rifampicin without any problem, but and rifabutin also can be used. And efavirenz can be used with both rifampicin and rifabutin also. Nevirapine should never be used, neither with rifampicin nor with rifabutin, because of high hepatotoxicity. And boosted PI In boosted PI, there is drug interaction with rifampicin. So we should not be using rifampicin in adult. However, in pediatric group receiving PI and rifampicin simultaneously, we can go for super boosting of PI. And rifabutin can be used in adults without any drug interaction with the boosted PI. Now, dolutegravir, it can be used both with rifampicin and rifabutin. In case of rifampicin, it has to be given twice a day, that is 50 milligram twice a day, with a gap of 12 hours. And in case of rifabutin, it has to be given 50 milligram once a day. And in raltegravir also, similar to dolutegravir, it can be used as per weight, but twice daily. I mean, 800 milligram twice daily. Otherwise, we prescribe it 400 milligram twice daily. But in presence of rifampicin, it has to be 800 milligram twice daily. And in case of rifabutin, it can be prescribed 400 milligram twice daily. So how to manage the drug-induced hepatitis? Because we know with ATT, the most common problem that a clinician face in the ART center is basically hepatitis. So how let us discuss a little bit about hepatitis. Now, transient asymptomatic increase in serum liver transaminases occur early in the treatment, and it doesn't need to be, and the treatment doesn't need to be discontinued if it is not associated with symptoms like anorexia, malaise, vomiting, or clinically evident jaundice. So the principle is that if the patient is having elevation of transaminase up to 3 times than the upper limit of normal, we can continue ATT if there is no symptoms. But if there is any symptoms of jaundice or the jaundice is apparent, then we need to stop if the transaminase elevation is more than 3 times or there is increase in bilirubin. But in case the patient is asymptomatic and there is no jaundice, but the transaminase goes up to 5 times the upper limit of normal, then also we need to discontinue ATT. The 3 symptoms which are very important, which points towards fulminant hepatic failure or acute hepatic failure are protracted vomiting, mental changes, and signs and symptoms of bleedings. In that case, we need to stop immediately all ATT. Now, once the jaundice or the transaminase goes down and the patient becomes free of any symptoms of hepatitis, then we can restart ATT in a graded manner. And usually it takes about 2 weeks time for the patient to recover from the toxicities of hepatotoxicities of ATT. And it also takes around 2 weeks time for the jaundice and transaminases to come down to the baseline level or below 2 times upper limit of normal. So in what are the toxicities which allows us to go for reintroduction of ATT, and what are the toxicity we should not attempt for reintroduction of ATT? First of all, hepatotoxicity, we can go for reintroduction of ATT once the enzyme, as I said, goes down below 2 times upper limit of normal. Ocular toxicity with ethambutol, we should never try for reintroduction of ethambutol. And immune nephritis, which is possible with rifampicin, we should never go for reintroduction. And non-serious cutaneous adverse reactions like no involvement of mucous membrane or the involvement of the body surface area less than 10%, we can go for the reintroduction of those drugs after a withdrawal of around 2 weeks time when the rash resolves. But in case of severe reactions involving mucous membrane or the more than 10% of body surface area, we should not go for reintroduction of the offending ATT. And in case of immune thrombocytopenia, aplastic anemia, nephrotoxicity, we should not, immune thrombocytopenia, aplastic anemia, we should not go for reintroduction of the offending agent. So immune thrombocytopenia, we know it is possible with rifampicin, while aplastic anemia is mostly produced by isoniazide, and nephrotoxicity is mainly by aminoglycoside, and reintroduction is possible once the patient resolves the symptom and the creatine, and based on creatine clearance, we can give titrated dose of aminoglycosides. In case of ototoxicity produced by aminoglycoside, we should not reintroduce. And for diarrhea requiring discontinuation of ATT, we can go for reintroduction in a graded manner, which will be discussed in the subsequent slides. Now, for nephrotoxicity, the dose of ATT and ART is based on the creatine clearance. The last row, if you focus on the last row, we have creatine clearance formula for male and female differently. That is, for female, the same formula for male is used, and the result is multiplied by 0.85. And based on that creatine clearance, we are going to titrate both ATT and ART. In case of ATT, Z and E, pyrazinamide and ethambutolnase titration, which is thrice a week. That is, every alternate day we are going to give. And for lemibudin, we are going to give if it abacavir-based ART can be continued if the creatine clearance is more than 30%. Now, how we are going to reintroduce ATT following those side effects are that first day we are going to start isoniazid 50 milligram. If tolerated, then on second day we make it full dose. If tolerated, we continue the isoniazid, and on fourth day we introduce rifampicin 75 milligram. If tolerated, we continue both isoniazid and rifampicin. Rifampicin is made increased to 300 milligram, and then on third day, rifampicin is made full dose. If tolerated, then on fourth day, there is after that, there is 4 plus 8 day, we are going to introduce 250 milligram of pyrazinamide. If it is tolerated, then we make it as 1000 milligram on the next day. And if tolerated, we continue the full dose. And thereafter, on the 12th day, we introduce ethambutol 100 milligram first day, then 500 milligram. If tolerated, then we continue full dose. Then types of treatment outcomes and definitions. These are important to know because our ATT management of tuberculosis in the ART center is guided by NTEP, and for referral and record keeping, these terms are quite important. So let us revisit this treatment outcomes, which can be either cured, treatment completed, or treatment success. Now, cured are those microbiologically confirmed TB patients at the beginning of the treatment who were smear or culture negative at the end of completion of treatment of tuberculosis are labeled as cured, while treatment completed is those cases where the sample is not available or we could not confirm microbiologically, then but there is no sign and symptoms of tuberculosis, and complete duration is taken. Complete duration of ATT is taken by the patient, then we call it as treatment completed. Cured and treatment completed both comprises treatment success. Now, determination of the drug-sensitive TB treatment outcome. First was, previous slide was types of treatment outcome, and here it is treatment outcome definitions, different definitions. That is, first one was treatment success or cured or treatment completed or treatment success. But here other possibilities and their definitions. The failure means any TB patient whose biological specimen is positive by smear or culture even at the end of the treatment is called as failure. And failure to respond means the patient is a drug-sensitive TB and have received adequate amount of adequate dose of ATT as per the weight band for 12 weeks and was totally compliant and but failed to convert microbiologically to negative side, and we call it as failure to respond. And loss to follow-up, any patient who has interrupted treatment for more than 1 month is called as loss to follow-up. And not evaluated are those patients who are transferred out. So, for example, we have started the patient on ATT, and before the completion of the treatment, the patient was transferred out. Then we call it as not evaluated because we could not do the test at the end of the treatment. Neither we know the report of that treatment. Now, treatment regimen change are those patients. So, for example, a patient was diagnosed as TB by CVNet, and the rifampicin was sensitive. And we started ATT 4-FDC in the ART center. And at the same time, we sent samples for first-line LPA for knowing INH resistance. And after some time, its report come as INH resistant, then we will be referring the case to DRTB center for change of regimen. And here, in all these kind of cases, we are going to label them as treatment regimen change. And died is a person who died while the ATT treatment was going on. So in ART, beginning of ART in a case of TB patients, so ART should not be started first, as we discussed at the beginning of today's session. So once the patient is receiving ATT for say 2 weeks, then and once the patient tolerates the ATT and symptoms improves, then we are going to start ART treatment within 2 weeks of initiation of ATT. Exception is the TBM, that is tubercular meningitis, where the initiation of ART to be delayed to at least 4 weeks, but it has to be started within 8 weeks of initiation of ATT because of fear of iris. And in case of meningitis, iris has to be iris can be fatal if it is not diagnosed properly. And in such cases, we should have a low threshold to start corticosteroid also. Now, ART in PLHIV with TB co-infection. Now, any PLHIV weighing more than 30 kg, more than 10 years, the preferred regimen is DTG based, that is TLD. And here we can start rifampicin based ATT. Rifampicin based ATT. Just a minute. Extremely sorry. Now, so we are talking about PLHIV more than 30 kg and age more than 10 years. The preferred regimen is TLD. And here we can start ATT with rifampicin. Just we need to double the dose of dolutegravir. That is 50 milligram in the morning and TLD at night. And the ATT would be the same, 2 HRZD and 4 HRE. Now, PLHIV with a body weight of less than 30 kg or less than 10 years, the recommended ART regimen is abacavir, lamivudine, and dolutegravir. Here also, we are going to give double the dose of dolutegravir, that is twice daily 50 milligram. And the ATT is the usual 4-FDC. We can prescribe for 2 months and then 3-FDC for 4 months in the continuation phase. Now, PLHIV with high serum creatinine values, we can give abacavir without any dose adjustment. We can also give dolutegravir without any dose adjustment, but we'll have to adjust the dose of lamivudine, which is as per the creatinine clearance. If the creatinine clearance goes down below 30, we are going to titrate lamivudine. But if the creatinine clearance more than 30, we can continue lamivudine with the same dose, that is 300 milligram. 300 milligram. Now, and the HRJD, as we said earlier, in case of nephrotoxicity or renal compromise, the last two requires dose titration, that is pyrazinamide and ethambutol, and we give it as thrice a week. Now, women of childbearing potential who do not wish to take DTG, we can give TLE. And with TLE, there is no requirement of any dose adjustment, neither on the ART side nor on the tuberculosis side. But if a patient is contraindicated for efavirenz, so for example, patient is infected with HIV-2 or HIV-1 and 2, or there is prior exposure of NRTI in the previous pregnancy, then we can start with lopinavir, ritonavir in the pregnant lady. But we'll have to substitute rifampicin with rifabutin. And in all those cases where we have made DTG twice daily, this dose has to be continued with the rifampicin. This dose has to be continued 2 weeks after the completion of the ATT, because the hepatic liver induction that has happened with the rifampicin takes time to come back to normal, and which is typically 2 weeks. Now, ART in PLHIV with TB co-infected, that is current ART regimen is with zidovudine or tenofovir or abacavir along with lamivudine and DTG. We know that dolutegravir can be given 50 milligram twice daily, and the usual ATT regimen can be continued. Now, for TLE, TLE or ZLE or ALE, there is no change required in the ART side nor in the ATT side. Usual ATT regimen can be co-administered with efavirenz-based regimen. Now, patient with either zidovudine or tenofovir or abacavir along with lamivudine and PI-based regimen. First, we try to substitute protease inhibitor with the dolutegravir-based regimen. If the patient did not receive dolutegravir earlier, or there is no, or the patient has not failed to DTG, then we can shift the patient to DTG, and we provide twice daily dose of 50 milligram DTG, and the usual ATT regimen can be administered. That is, with rifampicin, we can administer. If the PI-containing regimen has to be continuous, say for example, the patient is on second line or third line, then rifampicin has to be replaced. If the patient is on second line or third line ART, then we cannot change it to DTG. And in that cases, we will continue PI, but we will have to replace rifampicin with rifabutin. Now, if the patient is on PI-based regimen along with DTG, then we'll have to make DTG twice daily, and for PI, we'll have to change rifampicin into if the patient is on PI and DTG, the dolutegravir additional dose has to be given for the entire duration of anti-TB treatment, and not beyond. That is, patient is on rifabutin, so we need not increase the dose up to 2 weeks as we used to do in the case of rifampicin and DTG. And rifampicin must be replaced with rifabutin because the patient is on PI. Now, let us discuss a little bit of drug-resistant TB. But at the beginning, we need to say that when a person is diagnosed as drug-resistant TB, then the management is not done in the ART center. The management is done in the DTC or DRTB center. So we need to know not everything of DRTB, but we need to know the side effects of individual DRTB molecules regimen, and a few classification and a few terms we need to know as a ART MO. Now, the drug-resistant TB can be monoresistant, or it can monoresistant can be either HRTB or RRTB based on whether it is isoniazid resistant or rifampicin resistant, and it can be polydrug resistant TB. So a monoresistant TB is a tuberculosis whose biological specimen is resistant to one first-line anti-TB drug. So it can be either isoniazid, when we call it as HRTB, or it can be rifampicin when we call it as RRTB, or polydrug when the biological specimen is resistant to more than one first-line anti-TB drugs other than both INH and rifampicin. Because if it is resistant to both INH and rifampicin, it becomes MDR. Yes, MDR. Now, MDR TB, as I said, it is resistant to both isoniazid and rifampicin with or without resistance to other first-line anti-TB drugs. Now, pre-extensively drug-resistant TB is a TB case where the strain is MDR, along with it is resistant to one or many fluoroquinolones. We call it as pre-extensively the DRTB, that is pre-XDR TB. Now, XDR TB, there is extensively drug-resistant TB, is a TB which fulfills the criteria of MDR or RRTB and is also resistant to fluoroquinolones and at least resistant to one group A drug, that is either linezolid or betaquinil or both. Now, second line anti-TB drugs, their abbreviations, all these things are not required for us. But the side effects of individual drug-resistant TB is important for us to know because many of the side effects overlaps with the side effects of ART also. So, for example, levofloxacin, seizure, and headache is possible. Moxifloxacin, there is QTC prolongation with prolongation, and with bedaquiline, there is gastritis, hepatotoxicity, QTC prolongation, dyselectrolytemia, myopathy. Linezolid, peripheral neuropathy, optic neuritis, and bone marrow depression. Clofazimine, reddish discoloration with skin, QTC prolongation, and phototoxicity. Cycloserine, psychosis, depression, insomnia. And terizidone, it is headache, tremor, insomnia, depression, convulsion, altered behavior, and suicidal tendencies. Ethambutol, we have already discussed. Delaminid, QTC prolongation. Imipenem, celestine, diarrhea, nausea, vomiting. Meropenem, fever, chill, lightheadedness, dizziness, sweating, rapid shallow breathing, skin rash. Amikacin, nephrotoxicity. Ethionamide, prothionamide, and PAS can give rise to gastritis and hypothyroidism. So integrated drug-resistant TB algorithm, these are basically followed in the DRTB center. And what is important for us in the ART center, we should be knowing that what DRTB regimen the patient is on and what are the different kind of side effects available with the individual ATT of that particular regimen, and how it can interact and how the side effects can be multiplied by the side effects of ART. So MDR-TB, short course with the bedaquiline, these are there. But basically in an ART center, we receive patients who are already been put on drug-resistant TB regimen. And if we can know the drugs that are being used and their side effect profile, then for a ART-MO, it is easier. It is possible to manage that case. So again, these are the flow diagram. These are followed in the DRTB center. We can bypass it. Then monitoring. Yes, this we need to know because we need to monitor clinically and by follow-up sputum microscopy and sputum cultures. But these are also been done by NTP to determine the outcome of DRTB treatment in accordance with NTP guideline as cured, treatment completed, failure or not evaluated, regimen change, lost to follow-up, or died. And the definition of all this treatment outcome was also discussed in the previous slide. Now, ART for TB, HIV co-infected patients on bedaquiline or delaminid. So DTG-based regimen should be the ART regimen of choice. And if PLHIV are already on NRTI and DTG-based regimen, the same is to be continued. And because it is drug resistant, so there is no requirement of increase of dolutegravir-2 BD because there is no rifampicin in the second line in the DRTB. Now, if PLHIV is on NRTI and PI boosted ART regimen, then we substitute it with DTG-based regimen on the ART side. And for PI-based second line or third line, we cannot substitute DTG. So we need to coordinate with SASAP and the linked DRTB center because experts are there in the SASAP and we need to take their help. With PI-based ART, intensive monitoring is required. If at all we need to continue PI-based regimen along with the DRTB regimen, then we need to closely monitor the patients. And with delaminid, it is a bit better because it doesn't interact with tenofovir, efavirenz, or lopinavir, ritonavir. And concurrent use of efavirenz may not require dose adjustment. Now, coming to CLHIV, infected with tuberculosis. First of all, the message is that in pediatric patient, Many a times, a patient can exhibit signs and symptoms of tuberculosis, but this may be due to some other causes of respiratory tract infection. Say, for example, it can be pneumonia, it can be tonsillitis, upper respiratory tract infection, lower respiratory tract infection, other than tuberculosis also. So it is best to consult with the pediatric department for the evaluation of tuberculosis in a pediatric patient. Now, this pediatric patient, unlike adults, with the delivery, they are having the HIV, and there is immune compromisation. And because of that, the primary infection with tuberculosis, which we all take from the community, it may not be contained just like a normal individual. So we can have primary progressive TB in the pediatric or newborn patient with HIV. And EPTB is also more in the case of CLHIV. Multi-drug resistant is also more common with CLHIV, and there is high case fatality rate in pediatric HIV-TB. And now, for symptoms of tuberculosis in pediatric patient, we already discussed earlier. Just a recapitulation: it is fever, cough, failure to thrive, weight loss. There is more than 5 kg of compared to the highest weight in the last 3 months, and poor weight gain or no weight gain in 3 months, or contact with the case of TB. Here, it is important to know that we say the patient is having contact with the TB case if it is within the last 2 years. So if we ask the attendant if there is any case of TB in your house, they may not say. They may say that there is no one, because they think that they had a case long back which has been cured, so they may not say. So we need to specifically tell them if there was any case within the last 2 years in your house. Then only we'll be able to know whether the patient was, the CLHV was in contact with the TB case or not. But these are for pulmonary TB, but for extrapulmonary TB, we need to look for lymph node enlargement, headache or confusion in case of TBM, backache, joint pain, or spinal deformity in case of bone TB, chest pain, tightness in the chest, respiratory distress, etc. in case of pleural or pericardial TB, abdominal pain, swelling, discomfort, and respiratory distress is possible with abdominal or peritoneal TB, and contact with the TB case. In the history, we may find that the patient was in contact with the TB case. Again, the diagnostic algorithm for TB in CLHIV is similar to the adult one. In case of pulmonary, where patient can produce sputum, we send for a CBNet test. But if the patient fails to do so, and which is the case in majority cases of CLHIV, we need to go for induced sputum, or for gastric lavage, or for bronchoalveolar lavage. In these cases, it is best to take the help of pediatric department. And for presumptive TB, we know where the infrastructure is not there or the sample is not available, then we either take the help of other tests, say for example, FNAC test, chest X-ray, or other radiological evidences of tuberculosis. In all these cases, it is best practice to take the help of pediatric department. And the treatment of drug-sensitive TB in CLHIV is again the same. Isoniazid, rifampicin, ethambutol, pyrazinamide. But the important thing here to know for ART center is that all the pediatric patient cannot be dispensed with ATT from the ART center, because we do not have the pediatric formulation in the ART center. We only have adult 4 FDCs and 3 FDCs. So older children, say for example 15 years 16 years patient, but below 18 years, can be dispensed with ATT from the ART center. And for all those young CLHIV, we need to refer them to the DTC. Now again, the dose are as per the weight band, pediatric weight band. So it is best to have this chart on the desk, and for older children, we are going to dispense it from the ART center, and for younger children, we are going to refer them to DTC, because we do not have pediatric formulation in the ART center. So if the weight is less than 20 kg and the age is below 6 years, then we are going to provide lopinavir-ritonavir based ART. And when the patient is put on a rifampicin-based regimen, then we are going to superpose the lopinavir-ritonavir. That is, in a boosting case, it is 1:4, but in case of super boosting, it is 1:1. That is, lopinavir and ritonavir should be equal in super boosting. Now, if the patient is 20 to 30 kg and weight is and the age is between 6 years to 10 years, then we are going to give it dolutegravir-based regimen. And here also, like adult, we are going to provide 50 milligram twice daily. And the usual 4 FDCs, pediatric FDCs, 4 FDCs can be used in this patient. And weight above 30 kg and age above 10 years, we provide TLD. And here also, just like adult, we are going to provide 50 milligram of dolutegravir twice daily, 12 hours apart. And we need to continue this dolutegravir for 2 weeks after completion of ATT. Now, this previous was the drug-sensitive TB. Now, MDR-TB, similar to adult also, MDR-TBs have been referred to the DRTB center, and all the medicines that were used as part of DRTB regimen in adult are not given routinely to pregnant children, but the DRTB medicines that are being used, the patient will also be receiving that. In adult, the DRTB list that we have seen, many of the molecules will be used in the pediatric patient to formulate the DRTB regimen. So if we know the side effects of individual DRTB molecule, ATT molecule, we will be able to manage such case in ART center. So criteria for diagnosis of probable MDR-TB in children is that contact with the known case of MDR-TB or close contact with the person who died while on ATT treatment, and close contact with the person who failed TB treatment, and non-responders or failure of a first-line regimen, and previous treatment with second-line medication. Diagnosis and treatment in CLHIV with children with HIV. Now, again, there are different possibilities. There is a short oral betaquilin containing MDR or RRTB regimen for 9 to 11 months. So all these decisions would be taken by the DRTB center. And we just need to know what kind of DRTB regimen, what molecules have been advised from the DRTB site, and what are their side effect profile, and how do they interact with the ART molecules and the side effects of ART molecules. Now, tuberculosis treatment in PLHIV on protease inhibitor, as we said earlier. If possible, we are going to change the lopinavir-ritonavir-based regimen or any PI-based regimen to dolutegravir-based regimen. And in case of drug sensitive, but in case of drug resistant, we are using rifabutin. Specifics, it is also drug sensitive. Here also it is drug sensitive, so we are using rifampicin. Now, if we are using rifampicin, then in case of children we can go for super boosting, but in case of adult, first we will try to change PI based regimen into dolutegravir based regimen, and we can provide it twice daily. And if we can substitute rifampicin with rifabutin, then we need not make it twice daily, and we can continue DTG-based regimen. Now, NTTB treatment initiation should be done as soon as the TB is diagnosed. We have gone through earlier, it is just a repetition. Even in patient with PI-based regimen, if substitution of rifampicin with rifabutin cannot be done immediately, one should not consider super boosting. It is because in adult, if you go for super boosting, the dose of ritonavir would be so high that the patient will not be able to tolerate it, and there will be lots of side effects. So we should not go for super boosting in cases of adult, but it can be done with the pediatric patient. So we need to replace rifampicin with rifabutin, and we should not go for super boosting. If rifampicin is continued for long duration, this will make the boosted PI ineffective, and the patient will fail in the ART side. Now, TB treatment in children living with HIV on protease inhibitor drug, as we said, we can increase it to 1:1 lopinavir-ritonavir as a part of super boosting, and we can give it with the rifampicin-based regimen. And in case of more than 6 years of age and weighing more than 20 kg, just like adult, we can go for substituting the PI-based regimen with DTG and provide the DTG twice daily, just like adult. And in case of pregnant lady and lactating woman, all the primary anti-TB drugs are safe during pregnancy and lactation. Among the second-line anti-TB drugs, amikacin, streptomycin are contraindicated in pregnancy. And the use of fluoroquinolones is also can affect cartilage development in fetus, so it is also not advisable. And ethionamide is contraindicated during the first trimester of pregnancy due to teratogenicity, and bedaquiline and delamanid are best avoided in pregnancy till there is more evidence available on their safety, because both the bedaquiline and delamanid are quite new in the program. So more of evidence is required to say beyond any doubt whether these are safe in pregnant ladies. Shorter oral bedaquiline containing MDR or RRTB regimen cannot be administered during pregnancy with DRTB. Among ART, DTG or efavirenz-based regimen are safe in pregnant women. And if the patient wants to opt out from the dolutegravir-based regimen, we should allow them to opt out, and we can start efavirenz-based regimen. So in case of renal impairment, as we said, isoniazid rifampicin doesn't need any dose modification. However, pyrazinamide and intravitol need modification. As per their dose, 3 times a week, we can provide both pyrazinamide and intravitol, and we should not provide daily doses. That is, on alternate day, we have to provide it. Now, TB associated with iris. TB iris may occur in up to 1/3 of patients who have been diagnosed with TB and have been started on ART. Usually it presents within 3 months of initiation of ART, but it can also present later. Commonly presents with the appearance of new or worsening signs of TB and TB signs and symptoms. That is, it is a paradoxical iris, because the patient is already on ATT. So we expect that the signs and symptoms of TB to go down, and with the introduction of ART, also with the boost with the recovery of immune system, we also expect that TB should go down. But there is precipitation of more signs and symptoms of existing TB. So it is a paradoxical iris. The symptoms are like, yes, we have said. At times, serious reactions such as meningeal TB, respiratory distress, massive adenopathy causing tracheal compression may also occur. So such cases require the use of anti-inflammatory drugs, including corticosteroid that we already discussed. Particularly in case of TBM, we should have a low threshold to use corticosteroid in case of iris. So general principles for prevention of TB in PLHIV at ART center, we all know that if the patient is not exhibiting any signs and symptoms of tuberculosis, particularly the 4S symptom, then we should go for TPT, initiation of TPT for 6 months, once in the lifetime of the PLHIV. And TB preventive therapy can be given even after the completion of ATT. So, for example, a person has been diagnosed with TB and has completed 6 months of treatment with the standard 4F disease of ATT, and immediately after that, we can continue IPT, that is isoniazid, for another 6 months, along with pyridoxine 50 milligram once a day. And because ART center is a place where we find more number of TB cases, both EPTB and open cases of tuberculosis. So there is more chances of infecting other PLHIV. So we need to diagnose the TB cases proactively, and we need to segregate them so that the person cannot transmit tuberculosis to other PLHIV. And we also need to airborne infection control need to be placed in position. So for airborne infection control, the main parameters, that the managerial measures, that is, the managers need to be sensitive about the need of airborne control, and administration also support that implementation of the airborne infection control in the ART center. And environmental control basically means the distance and wearing of mask, both by the PLHIV who are exhibiting signs and symptoms of 4S symptoms, and the healthcare worker also can use N95 mask. And personal respiratory protection that I said, the healthcare worker will be using mask N95 preferably. So this much about today's presentation. So
Thank you so
over
much,
to
sir.
Sweta.
Yeah, thank you so much, sir. Any questions from the participants? Please feel free to write in the chat box, or you can even unmute your mic. Any questions on HIV-TB? Also, there are no questions from the participants. Can we go ahead with the feedback form?
Yes.
Kiran sir, can we have the feedback form? Yes. All the participants are requested to please answer the feedback poll. There are 4 questions in all. Please answer all the 4 questions. All the participants are requested to please answer the feedback poll. Dr. Rajeeb sir, thank you so much for facilitating today's session.
Thank you.
Thank you to all the participants for patient listening. Also, can we conclude the session now?
Yeah, please.
Thank you. Sir, Rajeeb sir, are you there? There's
Please.
one question in the chat box, sir.
Please.
Duration of TB medicine in meningitis and TB bone.
Yeah, bone TB for 9 to 12 months in case of meningeal tuberculosis. And in case of bone, it can be 12 to 18 months.
Thank you, sir.
So, yeah, it depends on the follow-up investigation finding and the symptoms, and it has to be decided by the expert. That is, in case of TBM, it has to be decided by the neurologist, and in case of bone and the spine, it has to be decided by the orthopedician. So in case of bone TB, it can be 12 to 18 months, and in case of meningeal TB, it can be 9 to 12 months.
Any more questions from the participants? We can still wait. So there are no questions. Thank you.
Okay.
Kiran sir, we can end the session. Thank you.